Well, hello, my name is Nilofer Azad, and I am a medical oncologist here at Johns Hopkins University at the Sidney Kimmel Comprehensive Cancer Center. I have been focused on taking care of patients with colorectal cancer for the last 15 years, and I'm very happy to be here today with Cancer Nursing Today as a roundtable to focus on colorectal cancer with two of my colleagues, Rachel Klein, who's a nurse practitioner who works at Johns Hopkins as well, and Fatemeh Youssefi, who is also here representing nursing that takes care of colorectal cancer. I'd love to take just a brief minute to talk about maintenance therapy. So the data for maintenance therapy is that if a patient is given 5-FU and bevacizumab in the maintenance setting, that improves progression-free survival nominally. It does not improve overall survival. And so it actually gives us an opportunity to think about maintenance, whether we should do it or if we should just give people a chemo holiday. And so, Fatima, maybe you can start and tell us in your practice, which way do you go? Or if you do both, when and how do people make that choice?
So I'm not aware of how the providers in our institution make that decision as far as maintenance versus not giving the chemo holiday. That's I'm not sure about, so I cannot talk about that. But I do, again, go back to the fact that as thinking as an oncology nurse, as somebody that's maybe involved in infusion of these patients, coming back again every 21 days to receive this, that means again there is interruption in their lifestyle, basically, that if I'm coming back again to clinic every 3 weeks, so I cannot take 2 weeks of vacations, and so in that sense, versus chemo holiday. So if these patients quality of life call for it, that they really need that chemo holiday, I think just as a registered nurse and somebody in infusion area, that might be beneficial for that patients if it's been presented today, and to be assured them that if there are some activities coming back, there is an option to go back to flip on if that's the case. I don't know if that's helpful or not.
Yeah, no, absolutely. I mean, I think, and patients often will decide on that, especially when there's not an overall survival benefit. I do think it's important, though, for patients and us when we think about it to also understand how much better patients' quality of life can be on maintenance versus the whole shebang when they get all the chemotherapy and targeted therapy. Rachel, can you speak to that a little bit in terms of, let's say a patient is not comfortable, because there is an emotional part, right? I don't want to come off of therapy. I have a cancer in me. I have to treat it in some way. So I want to do the maintenance. But what do you think that we can tell them about what life will be like on maintenance therapy?
I think most people, when it's presented as that, as a reduction of intensity in their current regimen, are very pleased with that option. There are, as you said, some people who just are not comfortable with the idea of stopping therapy altogether or taking a chemo holiday just because of the mental component, truthfully, because we do have the data that you may have a longer time off of a more intensive chemotherapy with maintenance, but some people really aren't comfortable taking that break. So coming on to, let's say, if we describe it as getting 2 out of your 4 drugs, you've been on triplet therapy plus bevacizumab, and now you're just going to be on 5-FU and bev, or you might be on capecitabine and bev. Most people feel a sense of relief. I think there may be a component of additional education if they've previously been on the 5-FU pump and now we're switching them to the oral capecitabine. We do, as Fatemeh mentioned, we have to confirm that they're capable and willing to take pills twice a day for 14 days out of every 21, and that they're willing to come back every 3 weeks instead of every 2 weeks for their Avastin treatment. But in general, I think patients who elect that are typically very happy with that choice. And again, we leave it open-ended. This is an ongoing conversation. If it's not working for you, or you really need a break, or you want to take a vacation out of the country, we can always take a break starting anytime. We typically make a plan. I think people feel comfortable with a plan of, we're going to rescan you after a period of time. In our practice, it tends to be 2 months, could be 3 months, whatever you and your patient decide is a reasonable amount of time to kind of reevaluate and ensure that everything is stable on the plan that you've chosen.